good afternoon, and I'm glad, I'm hopeful that all of you are enjoying the format of this conference, or this forum. And as President-elect Corbyn has said, health is one of the most important aspects of any one individual life. So I'm just going to give some context to the conversation before we invite our two panelists. So obviously the escalating cost of healthcare and health insurance in particular is a pressing issue that affects almost every business and household in our community. Its implications for the well-being of our residents, especially retirees and those on fixed incomes, are profound and immediate. While our islands boast an impressive and ever-expanding healthcare infrastructure, in fact, there are 187 licensed healthcare facilities as of December 2024, the highest per capita in the region. Many of our community face significant challenges in accessing affordable healthcare and insurance. This paradox underscores a pressing need for dialogue and action. How is it that despite having the best medical infrastructure in our history, so many cannot afford the services they need? One of the most alarming trends we face is growing number of individuals who cannot even secure health insurance coverage, particularly retirees. These individuals have contributed to our community for decades, yet struggle to afford quality health care in their latter years. Compounding the issue, many are foregoing early preventative care because of cost barriers, which can lead to more severe health issues down the road. This cycle burdens both individuals and the broader healthcare system. These challenges prompt us to consider, is our current system truly designed to ensure equal access for all? Are there opportunities for reforms that can strike a balance between affordability, quality, and sustainability? So today's discussion is not just about identifying problems, but about exploring potential solutions. It is a call to consider whether it's time to review and revise our approach to healthcare and health insurance with the aim of creating a system that truly benefits everyone. This is a discussion that could shape the future of healthcare in our community. Today, we are privileged to have two distinguished panelists who bring a wealth of expertise and experience to this conversation. Their insights, born from years of dedicated service in the healthcare and insurance sectors, will be invaluable in our quest to understand and address the challenges we face. Firstly, let me introduce Shomari Scott, the Chief Business Officer at Health City Cayman Islands. You can give him a round of applause. He ensures that hospital remains at the forefront of medical excellence. His commitment to expanding accessible access to affordable, high-quality health insurance has had a transformative impact locally and regionally. Joining Shomari on this panel is Mervyn, the Health Insurance Commissioner for the Cayman Islands. Again, put your hands together. Mervyn brings over 30 years of experience in the healthcare industry with a career marked by leadership and service. As Health Insurance Commissioner, Mervyn plays a pivotal role in shaping the regulatory framework for health insurance in the Cayman Islands. His work ensures compliance with health insurance laws and acts and protecting the rights of policyholders while fostering a stable and effective insurance market. So these two experts offer unique perspectives on the intersection of healthcare delivery and health insurance. They will explore key issues such as care affordability, the evolving role of technology in health services, and the importance of sustainable insurance models that meet the needs of all segments of our economy and our community. And as we delve into these critical topics, I encourage you to engage actively with panelists during the Q&A session. This is a rare opportunity to learn more of the two most influential healthcare and health insurance leaders. Please join me in welcoming to the stage Shomari and Mervyn. Hey, Mari. So let's start the conversation with some perspective on both of your roles. So maybe we'll start with you, Mervyn. Tell us a little bit about your daily role and what you do and what you see so that people understand what role that you play in this health care industry.
Thank you so much, Will. Good afternoon, everyone. Yeah. So I am the Director of the Department of Health Regulatory Services and also the Superintendent of Health Insurance. So this position actually brings together the healthcare practitioners, healthcare facilities, and health insurance providers. So as Will mentioned, we have, as of December 2024, 187 registered healthcare facilities in the Cayman Islands, with 4 hospitals, obviously and a plethora of other outpatient clinics, etc. We also have, on the health insurance side, we have 8 approved insurers, meaning that those insurance companies are licensed by SEMA and approved by the Health Insurance Commission to sell health insurance products to residents of the Cayman Islands. So with that in mind, obviously we have the responsibility of licensing the healthcare facilities, inspection and licensing of healthcare facilities, to ensure that they all meet what we refer to as national standards. We also have the responsibility for registration and licensing of all healthcare practitioners, including doctors, dentists, nurses, professions that are allied with medicine, nursing, pharmacy, pharmacists, etc. So with that in mind, our department has been challenged literally on a day-to-day basis to keep up with what we see as significant growth in the healthcare marketplace.
And Shomari, what's your day look like?
Well, first, Will, thank you for having me here. And I just want to state that whoever is a part of the organizing committee, next time, think about the size of your biggest individual and then make the decision about what the actual seating arrangements would look like. I know Omari saw me coming up here testing the seat before just to make sure that it wasn't going to topple over. And I also would just like to state that if you came to the parliamentary luncheon, you'll notice that Will was always on me about the time. So we made sure we had a video. So it was 5 minutes. It was 5 minutes and 45 seconds, but it was still 5 minutes. And Omari was supposed to actually moderate this session, but Will decided that he's going to be here, and I think that's to make sure that we keep to the 35 minutes that's on this clock. But on a serious note, just want to state that day-to-day is a little bit of everything at Health City. Previous role, being the Director of Tourism, I was always looking towards what we can do to impact our economy at the greatest level and also help to fulfill the lives of Caymanians through that industry. So when Health City was sold to me to leave that role to actually come over there, it was really that we're going to create another industry with medical tourism that will one day be another pillar that the economy will be able to stand on. We know right now you have tourism, financial services, and potentially real estate, but let's get that 4th pillar with medical tourism as well in order to make sure that when you go through any recessions in the future, Cayman will still be resilient. So it's a little bit of everything, but high-quality healthcare at an affordable price with an organization that's world-renowned of being a disruptor and actually achieving the reduction of healthcare costs for citizens and or countries in any place that the parent company has gone.
Well, it's interesting because it leads me to the first question, which I'll ask Mervyn. I mean, obviously, the landscape for healthcare in the country has incredibly expanded over the last decade or even 2. So what do you think are the primary factors contributing to the rising healthcare costs generally, and how do they affect all residents, especially retirees, or I should say health insurance costs?
Sure. Well, firstly, if we go back, say, 20, 25 years ago, when we really only had 1 main healthcare provider, and that was the government. healthcare services for the Georgetown Hospital and the various district clinics. At that time, most residents, if they required any type of tertiary level care, they really had to travel overseas. And most of our residents were going to South Florida for health care. Now, those of us who are familiar certainly with the cost of health care, I guess certainly in the US, we would know that South Florida is perhaps one of the most expensive areas in regards to the cost of health care. But because of the proximity to the Cayman Islands, and because obviously of the number of healthcare providers that you have in the South Florida area, most residents gravitated to going to South Florida for healthcare.
And have you ever evaluated the different cost structures when you send somebody overseas for a particular procedure versus having that procedure done locally? Is there any comparative data to show us what that difference is?
Yes, we have certainly done that, and we have something called the standard health insurance fees, which is actually referred to as the usual, customer, and reasonable fees for the Cayman Islands. And those fees are actually based on the Medicare system that is utilized in the US. But having said that, the Medicare system is perhaps the lowest level of fees that is applied because it's a government system. It's based on, obviously, the US government system for Medicare and Medicaid patients. So our standard health insurance fee schedule is not necessarily set for the maximum, meaning the highest level of fees. It's more based on hopefully the lower side and perhaps to the medium level of services and care that is provided. So here, I guess the point I was trying to make earlier, that what is driving the cost of healthcare locally is that going back now from 2000 to where we are in 2024-25, we have, again, 187 healthcare registered healthcare facilities in the Cayman Islands with over 2,000 healthcare practitioners that are currently employed to obviously work in those healthcare facilities. So with the change of going overseas and having access to local healthcare providers, and I must say that generally speaking, I think we're lucky because not only do we have easy access to those healthcare providers, but the quality of care is comparable to what you can get in the US in many instances. But with that comes a price. It means then that we obviously have to provide the type of technology, MRIs, CT scans, etc. We also have to have the type of specialists, so to provide those level of services, and to ensure that those equipment and services are well maintained and supported. It does cost, and I think the biggest factor that perhaps is perhaps driving the cost also is the size of our population. So we have a population of less than 100,000. Let's say it's 85, 86,000 or so now. But if you look at health insurance and how health insurance is really set up, it's about spreading the risk. Insurance generally is about risk and how you insure risk. So with the small population, and certainly now with the increased level of facilities, access to those facilities, clearly it is driving up the cost of healthcare locally. But on the flip side of that, the convenience of having local healthcare providers who can deliver these services at a high level locally is certainly something that also have to be balanced in the equation.
Okay, so Shomari, let's turn to Health City, Cayman Islands generally, and also just talking about innovative strategies as to how do we address these things. So, in your view, how can healthcare providers, health insurance providers, and regulators innovate to improve the affordability and access, say even to the underserved populations? Because I think the Health City model that Dr. Devi Shetty introduced was revolutionary, so to speak, in the Cayman Islands environment.
Definitely, and obviously it's a multi-pronged issue, and I thank Mr. Mervyn for giving the background that he gave as well. When you actually look at GDP and healthcare spend as a percentage of GDP, in 2010, we were at 4.1%. By 2014, before Health City came, we had reached to 6.3%. It takes decades for countries to move a milli%, right, to move forward, but we jumped 2% in just 4 years. And if that trajectory continued to where we were today, prior to Health City coming in, we would have spent about $646 million more dollars on healthcare. So even though the healthcare is increasing, it would have exponentially have been worse if you didn't have a model which was innovative, bringing in Health City. And to Mr. Mervyn's point, there was an article in the Atlantic that spoke to the 20 most expensive hospitals in the US, and 7 of the 20 most expensive hospitals in the US are located in Florida. And there was a recent article that I read that had the most net revenue per patient hospitals in Florida, the top 20. One hospital that we like to send a lot of people to is number 5. Right? So even if the percentage has decreased with the amount of people going overseas, those that still go overseas, obviously, that's going to be at a high cost. So providing more of those services here at a lower cost, same high quality, was one way to stem that issue. But what we've seen over time, since COVID forward, is that line has started to take another uptick. And that's when we said, we have over $300 million invested here in the Cayman Islands. If we don't actually have a good look now on the payer side as to how we can stem the tide of costs, you're going to have high deductible plans, everybody's going to get the lowest level of insurance, and then the great access we have now, people won't be able to actually get the access. The great thing is we don't have to reinvent the wheel. There are models out there that are innovative, and that's where I talk about population health and integrated healthcare. I think it was the DG that was up here and was talking about the government and the fact that we need to move from outputs to outcomes. The actual value-based system actually looks at the outcomes of health. So just a simplistic model, just you actually get paid as a provider per individual, and your reimbursements are based on the actual health of the individual, not the actual service that's actually rendered. So now I remember sitting in rooms when I was new to healthcare, and there were overseas providers that would say, show me the incentive and I'll show you the performance. And I didn't quite understand what they were saying at the time, but what it translates to is that we're misaligned when it comes to healthcare, right? We provide more, we get paid more. It needs to be, is there a healthier population? And if there's a healthier population, then we get paid appropriately. I'll just give one example. They're doing this in Singapore, interestingly enough. They have an integrated care model in Singapore. But in Israel, they have 4 major hospitals, and one of the major hospitals does all of the diabetes monitoring. They're the same as every other OECD country, that they have 6.5% of their population suffers from diabetes. However, they're second in the world in regards to those patients presenting to hospital with an issue. And the reason is because of the integrated care model, they get paid based on actually taking care of the patient throughout. So they make sure they're in the homes, they use technology, and they manage the diabetes that those individuals don't end up at the hospital, and then you don't get the costs that are associated with them being at the hospital as well.
So obviously we have 187 licensed healthcare facilities. Public health, I see Lizette in the audience. reality is there are still some underserved populations in our country. And these are people, some of whom have spent their entire life given, their whole careers to the Cayman Islands, and they reach retirement age, and then suddenly they realize that the health insurance that they need for probably the most important part of their lives is very difficult to obtain because it's so expensive in some cases and increasing every year. So I guess what policy reforms, I guess I'll start with you, Mervyn, would you recommend kind of to reshape that paradigm so that Caymanians who need this access to this, and even residents who retire here, can get access to affordable health insurance?
Absolutely, thanks. Clearly, we have a population of retirees that is growing. And certainly as our population increases, we can expect that also to add to the number of persons who are 60 plus or 65 plus, who are retiring on a fixed income, but obviously will still need health insurance coverage. So if I could just, again, look quickly at where we are. We have 8 approved insurers for a population of less than 100,000. And clearly, they offer a number of health insurance benefit plans to the marketplace. And again, the current legislation only monitors and regulates the standard health insurance contract. And some people refer to it as SHIC or something a little bit less than that. But having said that, what the government of the day did back in 2000, 2001 was to set the minimum level of benefits that any health insurance benefit plan would have covered in it. Unfortunately, that standard health insurance contract has not really been updated or enhanced, meaning the benefits under that plan have not increased significantly over the past 20, 25 years. There was, in 2013, there was a slight increase in the benefits. But suffice to say that this standard health insurance contract does not meet the needs of today's healthcare marketplace. So one of the first things, obviously, I think, hopefully the next administration will look at the adjustment of the benefits under that standard health insurance contract. But having said that, again, that standard health insurance contract sets the base, right? What we really need is, especially for retirees, and as we grow older, obviously your health risk increases. So we need a plan or plans that really would be more targeted for seniors, individuals 60 or 65 years of age and older, meaning that a senior would not necessarily need things like maternity benefits, et cetera, et cetera. However, they're going to need more outpatient benefits. They're going to need more services in regards to emergency care, hospitalization, pharmaceutical coverage. Those type of benefits needs to be added in there. In the U.S., there's something called the Medicare system, which caters to those type of plans. And one of the things I think from the Commission point of view is that we would certainly want to recommend that. And what we would recommend is that there be actually a tailored plan for retirees, for senior citizens, with specific benefits that they would need and utilize. We would then make it compulsory for all of the approved insurers to offer that plan. And in doing so, we would have to actually have the premium rate for that plan actuarially determined so that all the approved insurers would offer that plan, and it would be at a premium rate that would be obviously set and determined as being fair and reasonable to the consumer and also to the health insurance company. Having said that, we did an exercise, an actuarial review, and such a plan would cost approximately $1,100 a month. And this was like 2-3 years ago. It may increase a little bit by now, but 2-3 years ago, the premium would have been like $1,100+ per month. The average retiree still would not be able to afford that type of a premium rate on a monthly basis. You know, obviously retirees would be on a fixed income. So what we would recommend that we suggest that government would have to subsidize that premium rate based on a needs assessment basis. So that's one of the recommendations that we would put forward.
Because obviously with people who may not be able to afford health insurance when they reach retirement age, or some of the other folks who just don't have health insurance because they're kind of falling away from the system, they're not getting wellness benefits, they're not getting their checks, and oftentimes when they present to the public, most of the time to the public health and the hospital, the country really has to bear the expense, a very high medical cost for those folks who, if they were diagnosed 5 years ago, maybe whatever they had contracted or whatever happened could have been addressed through some preventative health care at an earlier stage. So let's talk about that, Shomari, about, you know, does the paradigm shift have to be that we would be encouraging our community to go for wellness checks earlier? And I hear the argument that health insurance generally is on use. So they look at 5 employees, and I can tell you that you've used this much, and it costs this, and by the way, your insurance coverage is going up by 7% next year. Is that the way this is going to continue to go?
Right. So I want to answer that in 2 ways, Will. So the first component is that the reason Health City has a sister company now that actually provides health insurance is trying to use that integrated healthcare model whereby the patient is at the center and you have the provider as well as the payer. And if you continuously use your benefits, then obviously the payer is going to go out of business tomorrow if there's too much in regards to overutilization. And if you keep denying the benefits that somebody needs on this end as the health insurer, then you're going to actually kick the can down the road. Then you have that event that you were talking about, and you present at an emergency room, and there's going to be a huge claim based on the disease profile that would actually happen at that point in time. So what we're looking to do is to actually have more frequency of preventative care, of wellness checks. Actually, Health City will be working to make sure that the executive health check is more or less free to the insurance company and to the person who has the insurance, to incentivize them to come in for the checks, to actually have more wellness within the package, so that we can actually catch things earlier and we can have that ongoing conversation with patients so that you don't have that heart attack 10 years down the line, 15 years or 20 years down the line. And I like what Mr. Mervyn mentioned in regards to the retirement component, and you said it, right? In a population this size, you kind of have to manage the risk. And a lot of people in the private sector who are Caymanians would have worked their entire life in the private sector with great insurance, and then for the most part, once they retire, they're not able to afford the insurance when they need it most. So they weren't using the benefits for the most part during their healthy years, and then when they need it the most are proud. And I hate to say it, they see NAU as the division for handouts. I've worked my entire life. I am not going to NAU is what would happen. They present at a hospital because after 2 and 3 and 4 and 5 years, they couldn't afford the checks that they typically should have gotten, and then we're paying for it on the back end. But I would like to look at it a different way, in that whichever government comes in needs to look at the model in and of itself and incentivize keeping people healthy. And in doing that, then you potentially will lower your healthcare costs, and then you will have more to go around to make sure you can take care of the stalwarts of industry that retire and then can actually retire in dignity as well.
And so, well, if I could just add to that, I think Shomari is making a good point in that From the Commission's point of view, we also believe that it's important for consumer education in regards to how you utilize your health insurance benefits. Let's face it, right? If you are overutilizing your benefits, meaning that you have benefits under your plan, and obviously if you have the need, you have to use it. But if you're going to literally max out every single benefit under that plan, clearly the premiums for that plan is going to increase. So what I think from the Commission's point of view, we want obviously for consumers to be much more informed about the type of benefit plans that you have. And then we also want to work with the health insurance providers to put more emphasis on primary health care benefits, outpatients type benefits, wellness checks, those type of things. Right now, the focus is more on the inpatient type benefits, the higher cost level of care, more so than also putting benefits in plans that could really cover wellness.
Let's, because we have about 9 minutes left, so let's talk about innovation in healthcare systems, and what innovations do you think need to be introduced into the market so that maybe we can possibly lower costs and do different things differently? I know, there are some platforms that are being used by different healthcare providers. So maybe start with you, Shomari. I mean, what innovations does, I don't want to put Health City on the spot, but how can you improve your innovative systems to lower costs, and are you already doing it?
No, definitely. So obviously, as much telemedicine as we can have where people don't have to actually come into the facility, where it's low cost but still can have high impact, are the areas we're looking at. From a Health City perspective, our parent company, Dr. Shetty, obviously is a visionary. From about 5 or 6 years ago, he invested in having an office with 50 software engineers, because his vision is that you should never come to a hospital for healthcare, right? And through technology, we should be able to monitor patients. We should be able to go to patients to be able to help them along the way, because if you are going to leave it up to a lot of patients, they're not going to be compliant. And we're developing systems to be able to do that. And that actually dovetails into, I keep talking about integrated healthcare, which isn't a Health City thing. It would be a nationwide type of program, or population health, whichever way we decide to go. But in doing that, a lot of times now, even for monitoring at home, for instance, it needs to be medically necessary in order for insurance to pay. This is before it's medically necessary that we would be doing these types of things, where you have, whether it's wearables, monitors, that links into a hospital system or a care system, that they're able to check and see when there's a spike, when we all know of somebody who looks healthy, who you thought was the actual image of what health should be, that drops down and you're like, wait, what happened, right? So with these wearables, even for our more mature population, we would be able to actually see when there's spikes in their health and actually go visit or have them come in as well. And that's a public health type of scenario, using technology, not because it's medically necessary, but in order to keep tabs. If you align the incentive with keeping the patient healthy, then all of that technology and everything falls into place.
So, well, if I could just add one point also. I think, again, going back to the size of our population and the number of healthcare facilities that we have currently, I think what we would also like to see is more collaboration amongst the healthcare providers, meaning that, we have specialists but it doesn't necessarily mean that we have to duplicate having these specialists at every single facility. Because one, those specialists needs to be performing a certain number of procedures to obviously keep their skills up. So that is something that we would like to also encourage, more collaboration.
So are you seeing overutilization? Say I go to one facility locally, they tell me I need an MRI, I get one there, and then suddenly 5 years later, I need another MRI. Is that the type of stuff you're talking about?
Exactly. So we're having duplications of tests, etc. Because obviously we're not necessarily coordinating, and the patient may not be sharing that information. So we're repeating tests and mainly diagnostics tests that certainly could be adding to the cost of healthcare.
And the collaboration you're talking about is more of a unified technological system that can, one thing is, I hear in other countries you can have your whole medical history on your phone. Mm-hmm. So that when you go to one doctor or the other, you just transfer the documents that you wish.
Yeah.
Has that been introduced locally?
I think not at this time, but obviously with the advent of AI, I think we heard this morning, and where that's going, we see hopefully a lot of opportunities for using technology and AI to help us hopefully keep the cost of healthcare down.
And just to touch on what Mr. Mervyn said as well, I sat on a committee during COVID really, that was looking at social services and healthcare. And one of the items that came out of it was that there needed to be, and it was to do with pharmacy. The Pharmacy Act hadn't been updated since like 1972, 73, can't remember.
But we finally got it.
Right. But the Pharmacy Act hadn't been, at that point in time, hadn't been updated since 72, 73. And what the different stakeholders were saying that were in the room, healthcare providers, pharmaceutical companies, pharmacies and the such, was that there wasn't one system and database. So what they were actually finding was happening is that some patients were photocopying the actual prescription and would go to this pharmacy, get a fill, go to the next one, get a fill, go to the next one. And you can understand how obviously abuse would happen, but overutilization would happen in that instance as well. And to Mr. Mervyn's point, I think we have the most per capita MRI machines probably in the world.
And CT scans.
At some level, at times, as Mr. Woody would have said, there are always a few bad apples. They don't want to see the MRI imagery from another facility because they want to do the MRI themselves. Mm-hmm. So there's some of that as well. But when it comes to innovation, and I think this is where the DG and Minister Bryant left, or Deputy Premier Bryant left, but this is where the government comes in, that I'm fighting to get you more resources, Mr. Mervyn. They also need more resources, and maybe realigning resources to be the quality, as Ms. Sue said, watchdog. I would think, because we have so many medical services, free economy, you go where you feel is best, but the government is who should be the guardrails, as they said, to go in and see why did you actually prescribe that MRI and have the resources to do that in order to keep an eye on facilities and all of the mom and pop shops and everybody around to make sure that there isn't overutilization, and also to ensure that there's one system and that we can reduce healthcare costs. And in doing that as well, that also dovetails into your integrated healthcare, where you get paid for a population of people based on their health and not on them actually coming in to get that MRI and or that procedure.
Absolutely.
Okay, so we have to wrap up. I have about 1:30 left. So I'll start with you, Mervyn. What's your message to the next government? We have an election coming up, and what would you think? What would you say to the next government? What should be their first priority in healthcare?
Mm-hmm. Thank you, Will. So, based on the financial performance report, audited financial performance report, and going back to 2023, we see that the premiums that has been collected by the approved insurers is somewhere in the region of $399 million. So there is a lot of money in the health care marketplace. Of course, the claims is estimated to be like around $380 million. So the approved insurers are making some profit, but not exactly a huge profit. So what we see now, the average profit per year is somewhere between $11 and $15 million or so per year. And that's for the industry itself. So they're not making like $50 million or $100 million profit on the $399 million that they're actually collecting. So there is a lot of utilization. The bottom line is, though, I think we have to focus, as we said earlier, more on wellness and prevention. How can we incentivize that? Through the health insurance providers, through, obviously, consumers, through the patients. But more importantly, I think what we have to do is take a closer look at our current system to see if it is sustainable going forward. Again, we have a free market system where competition can be good, but I think in healthcare, we have to be careful with how we see competition because it could actually do the reverse for us. In other words, if you have an oversupply of healthcare providers, an oversupply of services and benefits, that may not work well for us going forward. So we have to monitor that very carefully. I think as Shomari said, obviously as being part of the healthcare regulatory system, we don't want to over-regulate the marketplace, but clearly we're going to have to put some guardrails in. And one of the things that we're looking at is really and truly the reporting from all of these healthcare providers. I think we have to make that compulsory in regards to if there is a bad outcome. I think that needs to be certainly reported, and we need to see what those trends are so that if we need to go to that healthcare provider and make certain recommendations, that we have the documentation and the justification for that.
All right, I'll give you, do you see the red? It's time.
Yeah, I know, Will. You always try to shut me up, Will.
But what's your wish list to give to the next government?
Oh, definitely. The wish list is just from an outcomes perspective. Stop looking at outputs. Let's start looking at outcomes. And when you look at outcomes, a lot of them are shared across departments, across ministries. And if you're actually looking at the outcome and not the output, then it becomes less of this is my area, because at the end of the day, it's about the Cayman Islands. It's about getting to that end goal of a healthy population. And I'll put a plug in here for the CMO, Dr. Gent. The STEP survey that he actually conducted recently in 2023, I was reading the language, and he said it was appalling how 10 years later, after they had done their last survey, the actual health of the nation is worse, right? So using what one of the panelists would have said here before, personal responsibility needs to come into it as well. 70% of our population, and this isn't Caymanian population, this is the population of the Cayman Islands as it is today, is 70% are overweight and or obese. A third have higher levels of cholesterol or higher levels of high blood pressure. So with the integrated care model, with the outcome model, looking at it with the view of making sure everybody is healthier, let's implement systems that government keeps it on the guardrails, but incentivizes the actual health outcomes versus doing the actual surgeries, and I think we'll be a far ways ahead.
Well, thank you very much. Put your hands together for the panel. Thank you.